My young post-surgical menopause patients that would come in complaints of severe pelvic pain. We would do hysterectomies, take everything out, uterus tubes and ovaries, lack of energy, lack of drive, lack of libido are the big things that would bring people in. But the things that we've been able to accomplish that has really amazed me and what brings people back is joint pain and muscle pain. And that's been one of the biggest game changers for so many women and men. Many women are diagnosed with fibromyalgia around the time of menopause, and they get placed on a lot of medications, none of which seem to be effective, and many of which contribute even more to symptoms. We treat them with testosterone, and many of their symptoms are totally alleviated. I thought we'd treat 3 or 4 or 5 patients a month. We're treating upwards of 150 to we're pushing 200 patients a month. And so what we came to realize is many symptoms that we weren't really accounting for were being alleviated with joint pain, muscle pain. As it turns out, testosterone is a very potent anti-inflammatory. And as a result of that anti-inflammatory effect, we see a reduction of Alzheimer's disease, which is, if you will, an inflammation of the brain and the accumulation of beta amyloid, which leads to Alzheimer's. So by reducing inflammation, we reduce that accumulation of beta amyloid. That's why it works so well with cardiovascular disease, but particularly joint pain and muscle pain. I think one of the things that concerns women in particular about any kind of hormonal therapy is the risk of breast cancer. Unequivocally, we know that estrogen can cause cancer, but it's cancer of the uterus. Now, we can prevent cancer of the uterus when we treat with estrogen by antagonizing that with the sister hormone, which is progesterone. Well, we see the same thing happening in the breast, but rather with testosterone. If you look at women who have been on super physiologic doses of testosterone, I think about the American Gladiator women, they have no breast tissue. Testosterone is anti-proliferative to the breast. So much like progesterone is anti-proliferative to the estrogen within the uterus, the testosterone is anti-proliferative to the estrogen at the level of the breast. So we actually see a reduction of breast cancer risk in many women, and that's being borne out in studies mostly done in Europe. There's a few studies that are ongoing in the United States that are showing great promise of dramatically reducing breast cancer risk. So we're actually seeing a reduction as opposed to an increase. Many of the data that we have had in the United States, based looking at hormone replacement therapy, we're using a bad drug in a bad way on the wrong people and the wrong doses. Many of our studies are based upon estrogens that are derived from the urine of a pregnant horse, pregnant mare's urine, Premarin, that's taken orally. Well, Premarin contains many different types of estrogens. Some are more deleterious to breast tissue. And not only that, we use many synthetics. So they tend to bundle all the hormones into one bucket when it's not all hormones behave the same. There's a big difference between synthetic testosterones and synthetic androgens that are delivered artificially as opposed to a bioidentical, or even better yet, human identical form of testosterone that's delivered subdermally and released by cardiac output as opposed to absorption and peak and trough. It's released by cardiac output, which is much more physiologic. With pellet therapy, we had the ability to individualize our dosing per patient. So each patient may get a different dose. And it's not only that, it's a physiologic dose, and it's delivered in an appropriate manner. When ovaries release hormone or when testicles release hormone, they release it right into the bloodstream. You don't regurgitate it and swallow it, so it actually goes right into the bloodstream. And it's also the same hormone that your body produces.